Hello, everyone. Greetings from Mass General Hospital here in Boston, where it's about 1 in the afternoon, and it's a bright, shiny spring afternoon here in Boston. My name is Peter Slavin. I'm president of Mass General, and it's a great honor for me to welcome you to today's program, which is entitled Lessons Learned from Global Vaccination Efforts. I hope you are all well and that you and your family members have had an opportunity to get vaccinated against COVID-19. Today we have people literally logging on from time zones around the world, and this event is also being recorded for those who could not join us live today. While we missed traveling to London and other places, we are grateful that this technology allows us to connect with friends from around the world. And I think you're in for a treat with today's program that's going to focus on COVID-19 and vaccination efforts related to it. But before we start the program, I just wanted to make a few introductory comments about what we've been through here in Boston and in Mass General over the last 15 months. As quoting somebody from the UK, this truly has been the best of times and the worst of times. I guess focusing first on the worst, we've seen terrible suffering, too many deaths, too many people suffering in isolation from their family members here in the hospital. And our staff has certainly faced the fear of caring for COVID patients, unsure whether they were going to get sick themselves or bring the illness home to their loved ones. On the other side, we've seen just incredible acts of courage, incredible innovation that you'll be hearing about, and it's really sort of brought out the best of the healthcare workforce. So it really has been a very mixed experience over this past year. I think this pandemic has also demonstrated to us how interconnected we are around the globe. Obviously, this virus, we believe, began in China and has spread to the US and to the UK, has affected almost all countries around the world. And our response to it has truly been an international one as well. For those of you who aren't that familiar with Mass General, we are the largest and oldest teaching hospital affiliated with Harvard Medical School. We're the largest hospital in this part of the United States, and we also have the biggest research program of any hospital in the United States. And clearly all aspects of what we do were brought into, we're called upon to respond to this pandemic. At one point, about a little more than a year ago, 40% of our hospital beds were filled with patients suffering from COVID. That certainly caused our staff to stretch and open spaces that aren't typically ICUs into ICUs, just as an example. Given the diversity of our patients, we had to provide translator services in so many languages, including Spanish, Chinese, and Arabic. And we also saw people from around the world reaching out to our website for health information. We saw international traffic to our website increased by more than 40%. I've been associated with this hospital for 36 years and have always been proud and appreciative of the 27,000 other men and women who make up this hospital community. But I've never been more proud of my fellow physicians, nurses, physical therapists, and other staff who have advanced not only our clinical mission, but our other missions, including research, to such a remarkable degree. During this period of time, our scientists have published more than 1,000 peer-reviewed articles related to either preventing, diagnosing, testing, treating, vaccinating against COVID-19. And that's really what this program is going to focus on. So you'll be hearing from one of our two international leaders in COVID vaccine development, Dr. Bruce Walker, who is the leader of our Reagan Institute, a multi-institutional collaboration among MGH, MIT, the Massachusetts Institute of Technology, and Harvard University, as well as your own Dr. Sarah Gilbert, professor of vaccinology at Oxford. So I want to thank you all for joining us, showing your interest in Mass General Hospital and in this very important topic. Our work would not be possible without the support of so many friends, both here in the US and around the world. And we certainly look forward again to the days when we can get together again and meet in person to discuss this or other important issues. So in the meantime, I wish you all the best and not only getting through the remainder of this pandemic, but in all future challenges we face in the years to come. I'm going to turn the podium over at this moment to our next speaker, who is none other than Dr. Tim Ferriss, who is a friend and former colleague at Mass General Hospital. Up until a few months ago, Tim was the CEO of the Mass General Physicians Organization, and it was really a privilege for me to partner with him in leading the overall enterprise known as Mass General Hospital. Several months ago, your government scooped him up, and we are very proud of the fact that Tim is now the National Director of Transformation in the UK's National Health Service. I can't think of anyone better suited to educate people here in the US or in the UK about how to transform health systems and make them more convenient, better, safer, more efficient for the people they're trying to serve. So it's my great pleasure at this point to turn the floor over to my great friend and great physician leader, Dr. Tim Ferriss. Thank you.
Peter, thanks so much. Thanks so much for that introduction, for the update, and most importantly, for your leadership of MGH through the pandemic and for the 2 decades before. MGH has been truly blessed to have your leadership. I'm honored to be here today in the role of bridging 2 storied institutions in the human fight against disease and suffering. The pandemic saw an explosion of scientific and medical collaborations, and none better exemplify this than between the US and the UK, because both countries have a long history of scientific collaboration with each other. When my departure from MGH to the NHS was announced, I received dozens and dozens of offers of introduction from my MGH colleagues to their close friends and collaborators throughout the UK. So it is not surprising that the largest biologic research hospital in the US is working so closely with the scientists in the UK, given the depth and breadth of the biotech community, both in Boston and in the UK. And so I'm so pleased then to turn to our guest, Dr. Bruce Walker, Professor of Medicine at Harvard Medical School and MIT, and an Executive Director of the Reagan Institute, and Dr. Sarah Gilbert, Professor of Vaccinology at Oxford University. Both of our guests played pivotal roles in the development of COVID vaccines and have agreed to provide us with some insights and observations on their experiences and answers to our questions. And I'm sure you, like I do, have a lot of questions. I want to first thank them both. Huge thanks to both of you for taking this time away from your work to help us all gain a better understanding of the vaccine development journey. So to start, I've asked our panelists to describe their work pre-pandemic so you all have a sense of how they ended up to be in the pivotal position that they were in at the beginning of the pandemic. What they've been doing since a high-level overview, of course it's too much to explain in a short time, but a high-level overview of what they are, what they've been doing, what they did during the since COVID began, and then what the future of their work looks like as a result of COVID. So we'll hear from my my longtime friend Bruce Walker first. So Bruce, take it away.
Great. Can you hear me okay?
Yep.
Thanks very much, Tim. So I originally came to Mass General actually 3 weeks after I graduated from medical school as an intern to train in internal medicine. I was really excited to come to a place where I thought everybody knew everything about every disease. And it was only a few weeks later that I encountered a patient that had 3 different infections and 3 different cancers all at the same time. The doctor said, "We have no idea what this is. You'll probably never see it again." And 2 weeks later, there was another patient just like it. And that was really the beginning of the wave of a new pandemic, HIV. I decided as a physician on the front lines that we were really going to be the ones to see new diseases as they arose. And if we didn't learn from patients, we would watch a lot of people die. And so I pivoted to become a physician scientist, where I trained in infectious disease and saw AIDS patients, but then at the same time worked in the laboratory trying to figure out how the body fights back against that disease and why it usually loses that battle. In that process, I developed a close collaboration actually with Oxford University through Philip Goulder, and our work took us to South Africa at the heart of the epidemic there, where we helped to establish collaborations to work on that pandemic. And it was really through those interactions that led me to be introduced to Terry and Susan Reagan, with whom I had a conversation about the fact that we were not making the progress we should be against that particular pandemic. We had gone a couple of decades without a vaccine. And the point I made was that I thought there was a lot more knowledge that could be applied to this problem, but the way that science is set up, it was very hard to access those individuals from other disciplines. And to our gratitude forever, Terry and Susan gave us funding to establish a new institute, the strategy of which was to draw on scientists from multiple different disciplines to work on really big global health problems. And the first one was working on an HIV vaccine. That was the Reagan Institute. So one of the founding members of the Reagan Institute was Dan Baruch, and we went forward with a vaccine concept based on a cold virus and made great progress, and actually have a trial in progress right now in Africa that we're very optimistic about, based on the preclinical work that's been done. And it was actually through that connection that in January of 2020, I found myself in South Africa with where I teach a course to MIT and Harvard undergraduates each year called Evolution of an Epidemic about HIV. And one of the students from MIT had just returned from a town in China that I'd never heard of called Wuhan. And she started getting text messages every day from her family saying that something really dire was going on with a new pneumonia there. At the same time, one of the teachers that I'd brought along with me was a former trainee, Diana Brainerd from Gilead. And she was getting calls every day asking if she could release a drug she had developed for Ebola to try and test against this new pneumonia, which ended up being due to a coronavirus. That drug was remdesivir. So I really felt like I was sort of at the center of this pandemic, or the vortex of this new disease right at the beginning, and realized that this was really what the Reagan Institute was established for, was to try and take on big challenges. So we immediately in January started working on it and pivoted from our work on HIV to use those same platforms to address the COVID pandemic. And that led through Dan Baruch's work to the development of a vaccine that's now been distributed by Janssen worldwide. And at the same time, we established something called the Massachusetts Consortium on Pathogen Readiness to basically try and bring together people from across the local microenvironment here with people from Tufts, MIT, BU, UMass, and MIT to work together on trying to pool our knowledge to advance our efforts. And that has resulted in about 500 people joining in a concerted effort that's really been one of the most amazing experiences I've had in terms of scientific collaboration. Going forward, we're in this for the long haul. I think it's really important, and underscored by this, that pandemics are going to be things that we're going to continue to encounter. And I think we're in a position to be able to contribute to that. And we plan to continue to do that. So Tim, I'll stop there with that brief introduction. You're on mute.
Thanks. So I'll have to remember the mute button. Bruce, thank you so much. And Sarah, I'm really looking forward to hearing your story.
Thank you, Tim. Thank you for the introduction. So I've been at Oxford University for 27 years now, and for most of that time I've been working on the development of new vaccines. Before COVID, I was working on the development of vaccines against a number of pathogens that have caused outbreaks in the past, although not pandemics. These include Nipah virus, Lassa fever virus, and Middle East respiratory syndrome coronavirus. To do this, my research group uses a vaccine platform technology. We've spent many years developing and understanding the technology, which we can then use to produce vaccines against different pathogens by adding in the genetic instructions to produce one of the antigens from that pathogen. The technology we developed is a viral vectored vaccine. It's made using an adenovirus, which is one of the viruses that can cause a mild respiratory tract infection or the common cold. And we all get adenoviral infections throughout life. So having an adenovirus in the body for a short time is not a new experience for us. To make a vaccine, we've removed a gene from the adenovirus so that when we use it as a vaccine, it can't spread through the body. Then we add a gene to provide the instructions to make the vaccine antigen. And when someone is vaccinated, they get a very short-lived adenoviral infection from which the majority of the protein produced after vaccination is the vaccine antigen, the one that we want the immune response to. That prompts the body to make a strong immune response to that antigen and protect them if they were then exposed to the pathogen the antigen comes from. So it's a very adaptable technology. We can use it to make lots of different vaccines very easily. We chose to use this technology because we knew it could be manufactured at scale to make large numbers of doses. It's inexpensive to produce, it doesn't require frozen storage, and it produces strong immune responses even after only one dose. All of those characteristics are important to make a vaccine against an outbreak or pandemic pathogen. So when we first heard about a novel coronavirus causing infections in humans, we began to make a vaccine against it at the earliest possible opportunity. 65 days later, we began clinical trials and partnered with AstraZeneca, who set up multiple supply chains to produce the vaccine around the world. The vaccine is now licensed for use in 170 countries and 500 million doses have been delivered to date. We were able to produce, test, manufacture and deliver the vaccine because we'd done so much work on the platform technology before 2020. We already had data on the induction of strong immune responses against MERS spike protein, so that's another coronavirus spike protein, and I was confident we could repeat that success with SARS-CoV-2. We still had to complete all of the stages of clinical development, but we planned ahead so that we could move from one stage to another as quickly as possible. In normal times, vaccine development is a stop-start process with a lot of time spent securing funding for the next stage. By the end of April 2020, our funding was assured. The regulators worked with us to review each new piece of information as it became available. The vaccine was licensed for emergency use in the UK at the end of December, and vaccine rollout began in early January. In recent months, I've been working with AstraZeneca to optimize the pipeline for the production of new versions of the vaccine tailored to the variant viruses. That doesn't necessarily mean that there will be a switch to a new version of the vaccine, but we will have new versions ready in case they're needed. Soon, I hope to return to the work on other vaccines, which has been held up by the pandemic. But we've learned a lot from COVID, so that should now help us move more quickly. I also want to do more work on technology development so that we can have better, more easily deployed vaccines in the future. Unfortunately, we know that disease outbreaks and pandemics will happen again, and we need to be better prepared for the next time.
Sarah, thanks for that great overview. Well, I can't help but comment from listening to both of you, what an extraordinary the past year and 4 months, 5 months has been. And I can only imagine the impact on your personal and professional lives to be at the center of what have been extraordinary scientific achievements that have made a huge impact on just the number of people living on the planet today, and will continue to have that huge impact. So I just want to start off, before peppering you with questions, with thanking you both for what your commitment, your passion, and your execution on what could only have been while engaging. It must have been really tough at times. So, having said all that, I'm really interested in, and maybe Sarah, I'll turn to you first this time, about the biggest challenge that the scientific community was faced? Maybe not the biggest, but could you pick a challenge or two that the scientific community faced, and how did they overcome that challenge?
Well, I think the biggest challenge that all the vaccine developers had at the beginning was that there are no vaccines in existence against a coronavirus, a human coronavirus. There are some against animal coronaviruses, but none against human coronaviruses. So we didn't know that it would be possible to make a vaccine against this novel coronavirus, and we didn't know what we had to achieve to do it. So for some viruses, you need a very, very strong immune response to get a protective immune response. For some viruses, such as HIV, it's proving almost impossible to do that. It's a different type of virus. But for other viruses, it's not so difficult to get an immune response from vaccination. And we didn't know where the novel coronavirus fell on that scheme of things. I did know that if we use the spike protein delivered in our adenovirus vector, we would be able to induce strong antibody and T-cell responses, because we'd already done that with our MERS vaccine. So we knew that that part was going to work. Whether it was going to be strong enough to provide the level of protection we were going to need, nobody knew. But we just had to work blind and plan how we would test if the vaccine was going to work as quickly as possible.
Great, Sarah. Bruce?
Well, I'll add a little bit different perspective in terms of, I agree with all that Sarah said. I think one of the other big challenges was just the fact that everything was shut down, and it was difficult even to get to work and be at work, and it was unclear what the real risks to people that were willing to do that actually were. Part of the problem that we faced in terms of trying to actually look at the vaccines that were being developed and trying to understand the immune responses that were being generated in people that were getting the disease and recovering from it or dying from it, which would help us understand what we were looking for in terms of effective immunity. One of the big challenges was getting access to patients. And the reason for that, you might not anticipate, but the problem was that the hospitals like MGH were completely overrun with patients. There was also a critical shortage of personal protective equipment. And just to be able to speak to patients, to be able to consent them to give us a blood sample so that we could start our investigations was just an incredible challenge that, you know, we didn't want to interfere with the clinical care, but there was this other aspect that was really critical. I think one of the other things that we encountered was that we established this thing called the MassCPR, the Massachusetts Consortium on Pathogen Readiness, to try and bring everybody together. And part of that was setting up a specimen repository that everybody could have access to. And the problems we ran into were logistical ones, just in getting the different hospitals and universities in the area to be able to interact with one another, which is something that was much more difficult than anticipated. But I think we made huge advances that will really benefit us in the future, to be able to do this in a much more streamlined way, where we can share samples and share knowledge without some of the bureaucracy that's required. So I'll stop there.
Great, Bruce. Both of your answers, highlight the sort of both the large picture conceptual issues that you were facing as scientists, but also right in the weeds practical issues about just getting patient blood samples during a pandemic. Maybe we'll turn to the human immune system for a moment and ask you both. So you are both world experts in the human immune system. How has your understanding changed over the past year and a half? What has COVID taught us about the human immune system? And particularly, what has it taught us that will be useful for future pandemics? Maybe Bruce, why don't you take that one first.
Yeah, that's a really important question. I mean, I think what we increasingly appreciate, and Sarah and I have appreciated this for a long time, is just how complex the immune system is and how difficult it is to ferret out what is actually helpful versus what is harmful. When the immune system gets activated, there are different soluble factors that are released that can cause collateral damage by something we refer to as inflammation, which is just kind of an overactivation of the immune system. And I think what we've come to realize in the context of COVID is that depending upon the timeliness of the immune response and the stage of illness, it could act both as friend and foe, where there's a period where it seems to be really doing a good job, and then if it doesn't actually clear the virus, then there's a period where it sort of continues to overexert itself and cause collateral damage that we think contributes to pathogenesis. But I think in terms of future pandemics, I think what we've come to recognize as just really incredibly important is to be able to come up with vaccines that work not just against SARS-CoV-2, but that work in a sort of pan-coronavirus way that will be able to, in a way, anticipate the next virus coming along, and with a vaccine that we can develop now, be able to target that future vaccine. That's a really difficult task, but it's something that's shared by SARS-CoV-2 and influenza and a variety of other viral infections. Those infections will arise, viruses mutate and evolve, and we have to be able to develop vaccines that will sort of anticipate that, and that's a tall order.
Wow, yeah. Sarah, tell us what your lessons learned has been about the human immune system.
Well, as a member of an academic research group, I'm very used to having lots of investigations into what's happening after vaccination. So we measure antibodies that bind the spike protein, antibodies that can neutralize the coronavirus. We're very interested in those. We want to know how well they cross-react with different variants of the virus. We look at T-cell responses, and then we start thinking about memory responses, the components of the immune system that are going to be stored for long term and help us if we encounter the pathogen in the future. And we need to think about how long those responses are going to last, how long people will be protected. And we measure lots of different ways that antibodies can work to protect us against the virus. And we end up with a very complex picture. So we end up with a lot of information, and then we're not really sure what we're going to do with all of this information. So as a vaccine developer, we want it to be really simple. We want to have one measurement that says we're going to do this blood test, and if it's above a certain level, this person will be protected. And if it's not above that certain level, then they probably won't be, and they need another dose of the vaccine, for example. Very, very difficult to achieve that. There's a lot of effort now going on to develop what we call the correlate of protection, so that we can understand if people are going to be protected or not. And what we're seeing is that there's no simple answer to that question. And also that early after vaccination, before the immune response has really developed very far, we're seeing a very rapid onset of protection. And yet later on, we need apparently a higher immune response to give us that same protection. So we're starting to think about what's happening early after vaccination, different from what's happening in a later time point after vaccination. And our focus is going to be very much for the future on how long will that protection last. We know that antibodies that are found in the blood and that can be quite readily measured will decline over time, whether you've been vaccinated or whether you've been infected. Those antibody titers will start to drop. That doesn't necessarily mean that that person won't be protected if they encounter the coronavirus again, because they have the immune memory. And so we have to think about how to understand the memory response as well as what's actually circulating in the blood at one time. So there's quite a lot of work to do to understand the complexity and then get some useful, simple answers out of it.
That's great, Sarah. I hope and expect that the the funding for that kind of research is going to reflect the new gravity of the implications for understanding those answers as soon as possible, right? I mean, it's very important to understand what you just described as soon as possible.
Yeah, and it's important to understand if different types of vaccines have the same correlative protection or if they're slightly different, because we shouldn't be assuming that all the vaccines work in exactly the same way. Maybe they have some different aspects to the immune response, and we need to understand that too.
I think it's also important, if I can just add that,
Please.
For example, Sarah was working on a MERS vaccine, and MERS had a 30+% case fatality rate, but it was kind of a blip. It got controlled rapidly, and that led to the people, sort of funding agencies moving on rather than really providing the support that Sarah needed to be able to take that to the depth that we need to understand all those things that she just talked about. And I think that's something that I think people really need to understand. And I think we as academics understand it, but it's not always easy to convince a funding agency to stick with a problem like that when suddenly nobody else is dying of that disease. But everything that we've been able to do with this particular pandemic in terms of vaccine development is all based on prior investments. A lot of it related to HIV, a lot of it related to critical findings about the original SARS, the original lethal coronavirus infections. But there wasn't the stick-to-itiveness that we needed in terms of funding.
Yeah. Well, Bruce, that brings up a really interesting additional angle to all of this, which is academic industry relationships. And so both of you, I can only imagine, have a longstanding relationships with industry. Of course you do, and of course you have. But I expect that was put in a new footing as a result of the pandemic. Can you talk about that? Maybe Bruce first about
Sure.
changes in academic industry and maybe things that you hope will be permanent changes or that could still be improved more than they have.
Well, I think we have to some extent a funding crisis in science in the UK and in the US in terms of the amount of investment that's made, which is I think not sufficient. I'm obviously biased, but I think that there's no way for an academic endeavor like Sarah's or ours to take a vaccine from concept to 1 billion doses delivered globally. There's got to be a commercial partner involved in that process. And so by definition, there have to be these relationships. And we were fortunate to have a relationship with Janssen that had been already established with the HIV vaccine that Dan had developed. But there are lots of complicating factors in terms of bridging that gap between academia and industry. But I think the future of science is really dependent upon us figuring out better ways to bridge that gap. There's a lot that industry can bring to problems like this. There's a lot that academia can bring to these problems. But there are all sorts of confidentiality and regulatory and privacy issues related to thwarting those interactions to some degree.
That's great, Bruce. Sarah, what are your thoughts about academic industry relationships?
The Jenner Institute, part of the Department of Medicine, where I work in Oxford, we've had many partnerships with different companies over the years. Our partnership in 2020 was actually a new one. We hadn't worked with AstraZeneca before. I did know a few of the people there because they have a flu vaccine, and I've worked on flu vaccines as well. But mainly our collaboration's been with other companies. But I think what made it easy for us to set up a new relationship was that within the university, we already understood a lot of the work that had to be done on the vaccine manufacturing. We have our own vaccine manufacturing facility on site, and that's where we manufactured the first batch of vaccine that went into clinical trials. We did that really very quickly at a small scale, but we'd already got plans in place for scale up of manufacturing. We knew that we could never do that as a university. In the future, we'll have the Vaccine Manufacturing and Innovation Centre, which will be a research organisation based quite close to Oxford, and that will be able to take manufacturing to the next scale, which might be manufacturing for phase 2, phase 3 trial in the future, but it will never be manufacturing at the scale that we need for global supply, which is where a large company has to come in and take over. So I think there's a real complementary relationship that can exist between industry and academia, with academia able to do things very flexibly, very quickly, think through lots of problems and different approaches to them, and then pass on quite a good package of data and materials to a company that can then apply their knowledge to scale everything up and get through the late stage of vaccine development, which is what we need to get vaccines licensed and delivered to people. And it was really important for us last year that vaccine manufacturing scale-up efforts started very early. If we hadn't had that, we wouldn't have been able to deliver the doses that have now gone out to people.
Yeah, go ahead, Bruce.
I think probably for a lot of people listening here, they don't realize that, you know, vaccine development to some extent is an iterative process. You make a vaccine, you test it, and then you tweak it to try and make it better. Every time you try and do that, it's a multi-million-dollar cost just to make the quality, the vaccine that you can actually deliver to a person. It's a different thing if you can sort of do it low scale in the laboratory for animals, but not for human use. And I think that that's one of the things that we in academia suffer from is the funds to be able to do those sorts of iterative vaccine trials where we need to make multiple different products.
Mm-hmm. I want to ask, see if there's progress. I've been dying to know the answer to this question. I think a lot of people have, and someone has submitted it in the question and answer. And so I'm going to ask you, where are we with our understanding of whether or not the vaccine isn't just helpful in the illness burden, but is helpful in reducing transmission? I know a lot of people have asked it, and someone has asked it here in the chat. So, Sarah, where are we on the evidence for reducing transmission? The context, I'll just add, in the question was that the question was why vaccinate young people if they generally don't get very sick, and it seems to hinge on this issue of transmission. So,
okay. So we know that the highest level of protection for the vaccines is against death, severe disease, hospitalization, somewhat less against mild disease, and less again against asymptomatic disease. But if the vaccines are preventing a lot of the asymptomatic disease, which they are, if people aren't getting the infection at all, then they can't transmit the virus to anybody else. We also know from our clinical trials that in people who are vaccinated and still do get infected, the amount of virus they have in their body is present for less time and is at a lower viral load. So there's just less virus in the people who've been vaccinated and then still become infected. If there's less virus there, there's less virus for them to transmit to anybody else. So it again reduces those chances. And there's also now data from healthcare workers where healthcare workers were vaccinated and the rest of the household wasn't, and they saw a 50% reduction in infections in the households of the vaccinated healthcare workers. So there's now multiple lines of evidence showing that the vaccines prevent against symptomatic infection, asymptomatic infection, and they reduce virus shedding even if you become infected after you've been vaccinated. So a lot of good evidence that The vaccines work in multiple different ways. In terms of vaccinating young people, I think we need to be vaccinating people of working age who are going out and meeting different people all the time. I'm on the fence about whether we should be planning to vaccinate children. The benefits to children being vaccinated are perhaps more difficult to calculate. And for the moment, when there's a real shortage of doses around the world, we'd be better off sharing those doses with other countries to really bring down the amount of virus and the number of cases in countries where the disease is spreading very rapidly, because that is driving the more mutations arising, and those mutations could come back and spread around the rest of the world. So we need to do something about that as quick as we can.
Great, Sarah. Bruce, will we need boosters? When will we know if we need boosters?
Yeah, so that's also a really important question. And early on, it was striking that people who became infected developed, developed antibodies, had sort of a little bit of an attenuated response to natural infection, and that's, we think, is because the infection itself impairs lymph nodes, which is the factory in the body where antibodies are made. In terms of vaccines, there's a peak and then a drop in antibody levels that are induced, and that led, I think, some people to conclude that these things were waning rapidly. But that's actually what happens with vaccines: is you get a peak and then it drops down. More recent data, including papers just published, show that, in fact, the antibody responses are longer lived than believed initially, and out to a year seem to be persistent. And in fact, there are new data just published showing that the kind of memory responses that Sarah was mentioning are actually induced by these vaccines. And you end up with long-lived B cells, which are the antibody-producing cells that reside in the bone marrow and are there then to be able to respond in the future. So I think in terms of protection against the current, from a vaccine, the vaccines that are being given now, I think the likelihood is that we will ultimately need a booster shot, but that may be a while, and it's not absolutely certain that that's the case. But the concern, I think, more is about variants, because we know that some of these variants, the levels drop. They're still above the level needed to be able to protect from disease, but as Sarah was saying, there are other variants that are being generated. For every single person in the world that gets infected, there's a chance for the virus to find a new mutation that is more lethal or more transmissible. We have to stop all of those, and there may come a point where the vaccines are just not protective against enough against variants, and that's a place where a booster vaccine could be really critical. And I know for all of these vaccines, those kinds of boosters are being generated, and those are based on training the immune system through a vaccine to recognize the new variants.
And of course, connecting your answer back to something that Sarah said earlier, if we had a blood test that could tell us whether or not your vaccine, your body's memory, and it was intact, so you do or don't need another vaccine, but we don't have that blood test because the research isn't there yet.
That's correct. I mean, there is a possibility that since this is a brand new coronavirus and nobody's seen it before, and if you get infected or get immunized, you generate some immunity to it that may in part be cross-protective if you encounter another coronavirus in the future. So it may be that this can ultimately turn into something that causes much less disease and is more like a common cold, but we just don't by any means know that at this point, nor can we count on that. Thanks,
Bruce. So I just want to encourage our listeners to submit their questions. I'm getting a lot of questions. One of them, well, they're all very, very interesting. One of them stands out, and that is is there any research on whether or not the vaccine influences the development of long COVID for the patients who break through? I guess that's a double-barrel question, right? Maybe say a word about the breakthrough patients, and then the long COVID. Sarah, do you have any thoughts on this?
Well, in the vaccinated people who do have breakthrough infections, they appear to be very mild in most cases, certainly in younger people. Sometimes in older people who have been vaccinated and then get infected, their immune system isn't functioning so well and they can have a more severe infection. But I'm not aware of any reports of long COVID in people who've been vaccinated and then get the breakthrough infection. Conversely, in people who have long COVID and then get vaccinated, there are some reports that their condition improves. It's not universal, but it does seem as though the vaccine in some of them is giving the immune system a kind of reset, and they're benefiting from vaccination.
Well, boy, that's a hopeful and probably unanticipated finding. Another listener is asking, and this is very much related to the conversation we were just having. I recently tested negative for antibodies despite being fully vaccinated. Am I protected from COVID-19? I don't know, Bruce?
Well, I was gonna push that one to Sarah, but I think the fact of the matter is we don't know for sure, and it relates back to what Sarah was saying, that we don't really know the correlative protection. There are some animal model studies that suggest that neutralizing antibodies are a correlative protection, but whether in that particular person that you mentioned, whether they might have some other arm of the immune response, either trained innate immunity or T-cell immunity that might provide some level of protection against severe disease, I think we just don't know at this point. We do know that the immune responses are lower in people, for example, who have other diseases, like who are otherwise immunosuppressed. But I think I should, before I mumble along here, I should have Sarah save me here and give her answer.
Well, I don't think we have the full answer yet by any means. We have seen that in studies following people who've been vaccinated with either the Pfizer or the AstraZeneca vaccine, which are the two most widely used vaccines in the UK, after the first vaccine dose, about 95% of people do have antibodies, and that increases, I think, to about 98% after the second dose. So there is still a small percentage after 2 doses who aren't making that measurable antibody response that we can pick up with a simple blood test. There aren't enough of those yet to know if they're protected against the disease. And we now have very low viral transmission in the UK, so it's going to be difficult to find out. But there's a lot of interest in following those people to see how things pan out for them, and also to do some genetic studies to find out why these people aren't making an antibody response and what other immune responses they do have. So I think it's a great opportunity to learn more about how the immune system works, particularly in response to vaccination, and what it means for those individuals.
Great. Now, Sarah, you mentioned something in our pre-meeting about the relationship between scientists and the press during COVID, and maybe you'd like to make some comments about your experience of the press and the representation of science in the press, who have a very difficult job to take complex material and put it into something that is going to attract the reader's attention and be accurate.
Well, I think the press, as you say, do have a very difficult job, and there have been good and bad outcomes from the reporting that we've had on the pandemic and the vaccine development in particular that I've been involved with. I think one of the really good things we've seen is that some journalists have been prepared to take the time to understand the science and think about how to report it to readers. And we've had a lot of information in the press for people about the different types of vaccines that we're using now. So I used to find in the past that when I talked to somebody about vaccines, people lumped all vaccines together, but now they're thinking about, we've got viral vector vaccines and RNA vaccines and protein-based vaccines, inactivated vaccines, and people have a much better understanding of how these vaccines are made and how they're a bit different, and what the different vaccines are. So I think that's a very good thing. We've also been working to provide as much information as possible, the background information, so that we can help reporters understand how the vaccines work with the immune system and what you can actually learn from clinical trials, all of that kind of thing. So that's been the really good side of things. And the bad side is that sometimes journalists want to be so quick to jump on one single piece of information and report on that without really understanding the context. And often as scientists, we are trying to draw information from lots of different sources. We want multiple lines of evidence that all fit together to give us the whole picture. And we don't focus too much on an efficacy readout from one clinical trial, because then you can't necessarily compare that to an efficacy readout from another clinical trial done in another country with different clinical trial endpoints. So people get sometimes too focused on comparing one number with another number. And I've even seen people compare two very similar numbers and say that this is better than that. Well, actually, a scientist would say there's no difference. You can't make any statement about that. So people then tend to kind of anchor on one single piece of information and base a lot of reporting on that. Whereas as scientists, we are trying to look more broadly and get a fuller understanding of the whole picture. Sometimes also we're being asked for clarity when there is not clarity, and it's not possible to report a very complex situation that we don't fully understand yet in very simple terms. And sometimes we have to accept that it's complex and we don't fully understand yet.
Yeah, a tall order. But I would say, just as an example, my 17-year-old daughter can recite, the protein, the S protein, the mRNA. These are words that were not on the tip of her tongue before. And so the whole population has gotten quite a bit of education. So in closing, I would just like to ask you each to reflect on what keeps you up at night in terms of your professional, your sense of professional obligation to the human race. What is and your position within that ecosystem? What keeps you up at night related to this? Bruce, do you want to try first?
Yeah, I mean, for me, the thing that I worry most about is that time is ticking and we need to get this pandemic under control. And I sort of relate back to what I said earlier about the fact that every single person, whether they live in the US or the UK or Africa or India, every time the virus infects somebody, the virus has another chance to come up with a unique set of mutations that can make it more lethal or more transmissible. And my worry is that we get the world sort of partially vaccinated and the pandemic continues, and that more people get infected, and we end up then with a variant that escapes the vaccines, and we start over again. So that's part of it. And really the other part of it is that it really brings into full focus the fact that viruses can be an existential threat to humanity. If we had a virus that had the transmissibility of SARS-CoV-2 and the lethality of MERS, then that would just be, overwhelming. And that I think says that we need to take this seriously. We need to approach this as a global community facing a common threat. We need to set up the surveillance systems that can basically alert us to the fact that something new is happening. We need to have the leadership that will respond to that when it does happen. And we need to have the commitment to continue to work on this, knowing that this is, there have been few things that have been more disruptive than what we've just gone through on a global scale.
Bruce, thank you. Sarah, last word here.
Well, I definitely agree with what Bruce was just saying. And I think one thing that is very clear and simple to understand is that we have to get vaccine doses equitably distributed around the world, because if we don't do that, we're going to find mutations arising in countries that haven't been able to vaccinate their populations. For me personally, what keeps me awake at night is that we've been talking about the future, more vaccine development, better understanding of the immune system, better collaboration between industry, academia, and public health as well, which is really important. And that's going to be great, but potentially we'll be in a much better position in the future. But my problem is the next 6 months to a year, how are we going to get there? Because we're finding that funding is going to be very difficult to come by. Government is not announcing what funding is going to be given to the research councils that we can then apply for. Staff will be completing their contracts and have no further funding to move on to. We've had a lot of disruption over the way the space is used in the university. We've had to pivot to do different activities, and now it's difficult to restart the original activities, and we don't have any more space to move into. So I think we've got to, as researchers, at least here, we've got a quite difficult time coming up for the next 6 months to a year. Hopefully we'll move into a much better situation in the future, but the immediate future is going to be tough.
Well, I think that's a really important point, and I think it underscores the fact that we as scientists really live grant to grant, and with no reserves, and having that flexible funding is absolutely catalytic.
Yeah. I'm want to, on behalf of everyone who is listening, I want to thank you both so much. It's been a real pleasure for me. I'm very fortunate to be able to know that I will keep having the opportunity to interact with both of you. So thank you very much. And Peter, turn it back to you for some closing thoughts.
Sure. Thank you, Tim. And first, I want to start by thanking Sarah and Bruce for their remarkable contributions to this pandemic. We really appreciate, as Tim said, this scientific effort that you've made, and hearing you over the last hour has really been a treat for the rest of us as you answered so many questions about where we've been and where we're likely to be going. And Tim, I want to thank you for rejoining us at an MGH event and lending your expert moderation and question asking skills to this event. It's great to have you associated with the MGH during this hour. And to everyone who attended today, I want to thank you for participating. I hope, like me, you really learned a lot about the vaccine effort related to COVID. Again, appreciate your interest in this topic, interest in Mass General Hospital, and I certainly hope that we will be back in London next year and can see many of you in person at that time. So thank you for joining us, and enjoy the rest of your day or the rest of your evening. Take care.